Okay. Yeah, so before we get started, I just want to run a quick poll for all of our attendees today. So, so please take a moment to fill out the poll if you'd like. It's optional, but we'd love to hear from you. Just getting an idea of your knowledge of recovery support services before Dr. Kelly starts discussing the science behind recovery support services. All right, yeah, we'll keep the poll open for a full minute. Also, as we have more attendees join us. All right, great. We are getting some great participation on our poll. And this will be, we'll show you all the results after a full minute. Yeah, and all right, so okay, I'm gonna end the poll and then we can see some results. All right. Okay. All right. So thank you everybody so much for joining us today for the very first webinar as part of our Recovery Science series. This is a SAMHSA funded initiative organized by the Recovery Research Institute at Massachusetts General Hospital, also co-sponsored by the Opioid Response Network. My name is Tingy, my co-host is Hazel, and we are both staff members here at the Recovery Research Institute. And today it is my greatest honor to introduce Dr. John Kelly. So Dr. John Kelly, our presenter today, is the Elizabeth R. Spallin Professor of Psychiatry in Addiction Medicine at Harvard Medical School. He is also the founder and director of the Recovery Research Institute at the Massachusetts General Hospital. He's also the associate director of the Center for Addiction Medicine here at MGH, and also the program director of the Addiction Recovery Management Service. Yeah, and without further ado, Dr. John Kelly will be presenting on recovery support services.
Thanks, Tingy. I'm John Kelly. I'm delighted to be here with you all. Thanks so much for coming and spending this hour together. Much appreciated. Hope it's worth your while. Hope it's minimally interesting, if not helpful, in your own life and work. Let me share my screen. Hopefully you can all see that, can you? Yeah? I'm getting some nods. Yeah, very good. Okay, so, and you can hear me okay? I'm hoping we'll have about 10, 15 minutes for questions at the end. So feel free also to put any questions or comments you have in the chat. We do save that chat, and we will, as much as possible, answer questions today. If not today, after today, we'll be able to respond to you. So thank you again. I'm going to talk to you today about recovery support services, science and practice. I don't have any conflicts. As Tingy mentioned, these are the sponsoring organizations for today's talk. This is a SAMHSA sponsored initiative run through the Opioid Response Network, which is funded by SAMHSA, and we are one of the partners of the Opioid Response Network. Just so you know, the Opioid Response Network provides technical assistance and consultation free to anybody who wants it. So this is taxpayer funded through the federal government, and we are trying to provide technical assistance and consultation to anybody who wants it in treating stimulant or opioid use disorders. So please, take advantage of this free opportunity. If you know people who need any technical assistance, consultation in these areas, contact through the website here, the opioidresponsenetwork.org. I also want to let you know that you can sign up for our monthly free recovery bulletin from the Recovery Research Institute, where we translate and summarize the latest science on treatment and recovery for the benefit of the public good. So please sign up at recoveryanswers.org. It's a freebie, and we're hearing a lot of good things about people like the breakdown of the latest treatment and recovery science that we do. So, having said all that, this is the outline of what I'm going to talk about today. I'm going to zoom out a little bit to provide some context of where we've come in the last 50 years since really the declaration of the war on drugs, because roughly right now, 2020, 2021, it marks 50 years since the declaration of the war on drugs under Nixon. I'll talk a little bit about that, what we've learned in the last 50 years, what's happened, and why we're talking about this right now. So to give it some context and some rationales to why we are where we are in terms of talking about recovery support services in particular. I'll talk about what is recovery and why people are focusing on recovery now as an organizing paradigm. I'll talk a little bit about the theory of addiction and recovery from a biopsychosocial perspective. I will outline the services, the latest services which have emerged and grown to address relapse risk, recurrence risk for SUD, and I'll talk about some future directions. Well, as I mentioned, 50 years ago, some of you were alive, some of you remember. You can also find this stuff on YouTube if you're interested. There was a lot of fear about Vietnam veterans coming back. Big opioid crisis was anticipated, never materialized. But this led to this declaration of a war on drugs under Nixon, and describing famously drug abuse, quote unquote, as public enemy number one. And again, just zooming out and thinking how far we've come in the last 50 years, I don't think we would refer today as it being public enemy number one, but rather the top public health problem that we have in the United States. In fact, it is the top public health problem in most middle and high income countries all around the world. If you look at the laws that have been passed over the last 50 years, it reflects this shift away from the more punitive rhetoric and harsh rhetoric and laws associated with mandatory minimum sentences, kind of draconian measures to try and address supply issues and minimize supply into the environment. And that's been replaced by more public health oriented laws like the Mental Health Parity Addiction Equity Act, Affordable Care Act, which are designed to provide access to care for people who need it. I was actually at this first ever drug policy reform summit held at the White House in December 9th, 2013. I was asked to attend and present some research I'd done on stigma and discrimination against people with SUD. But the point of this was really to formally mark a shift away from the punitive approaches to the war on drugs towards a broader public health approach. We've seen much greater focus in the last 20 years, last 20 to 30 years, in really understanding what the root causes of crime are. And if we can address those root causes better through proper treatment, proper addressing those root causes, we can prevent crime. And so drug courts have emerged as alternatives to incarceration, not only in law, in criminal justice, but law enforcement directly. Some of you may remember this fellow, Chief Campanello from Gloucester, who started this Help Not Handcuffs, the Angel program. He and his colleagues saw that people with addiction weren't criminals, but they were sick people that needed help, they needed treatment, and it was pointless to arrest them, but rather to provide access to care. And so he started this program, which was basically designed to, as a police station, to function as really as a public health initiative and help people find treatment. Quite remarkable when you think about that, how that shift has happened in the last 50 years. I was at the United Nations back in January last year, presenting some research in Vienna on stigma around addiction to this international body. And I came outside, and this was outside the United Nations. The only monument outside the United Nations. I thought this was quite striking, so I took a picture of it. It says, dedicated to all those affected by drug problems worldwide. Drug problems are preventable and treatable. Again, I thought that was quite remarkable and stunning, given that's outside, the only monument outside the United Nations building in Vienna, when all the other problems in the world, of course, are going on as well. So I think the zeitgeist is changing. Our approaches are changing, of course, the way that we are viewing and understanding addiction more broadly, but also in terms of how we address it, treat it for those who meet criteria for a substance use disorder. I don't think we necessarily associate the birth of these institutes with the war on drugs, but the war on drugs, of course, under that administration, really marked a large-scale appropriation which founded these institutes. Back in 1970, the National Institute of Alcohol Abuse and Alcoholism was founded, just celebrated 50 years. In 1974, NIDA was founded. And then 1992, SAMHSA and CSAC to disseminate findings for the benefit of those in need across treatment providers. And I'm going to get to kind of the rationale of how we've come to arrive now at this focus on recovery support services, because we've really learned a lot that's really placed us here, I think. When we think about the paradigm shifts that's occurred during the last 50 years. So this is really reviewing kind of where we've come from and what we've learned. Think about what we did not know 50 years ago, what we know now as a result of all the research that's been done principally by people funded through NIDA and NIAAA, who's funded 90% of the world's research on addiction. We have learned, for example, that about half the risk for addiction is conferred by genetics, something we did not know clearly 50 years ago. We also have learned about the neuroplasticity, how the brain changes as a function of our behavior all through our lifespan, but notably in response to these abnormally high potent cues or exposure to substances which cause both neurotoxicity and radical neuroadaptation to the presence of these abnormally high stimuli, potent stimuli. Also, not just, of course, as a function of exposure do they change, but they change in the absence of the drug. So we also see recovery of brain function and structure as people recover. These are things we did not know 30, 40 years ago, let alone 50 years ago. Stages of change. Some of you may, this is kind of out of fashion now, but still important, I think, because it gave rise, importantly, to this notion of ambivalence. This I do and I don't. About the middle 60% of people that we see in specialty care are struggling with this issue of making a decision about change or not. And so this gave birth to different clinical paradigms, most notably motivational interviewing. The idea that what people really need is not a good talking to, but rather a good listening to. We've had relapse prevention come along in the 80s, which recognized that it's not just about quitting, but how do people stay quit. We've learned about contingency management, the fact that swift, certain, modest consequences can shape behavioral choices, and very powerfully in addiction. Effective medications, both for alcohol and opioids. Of course, we're working on medications for other SUD as well, but most notably, of course, in the present crisis, the significance and importance of buprenorphine, methadone, and extended release naltrexone. Harm reduction strategies, again, have become critically important in light of the current opioid crisis. Which brings me to also this fellow and people like him understanding that addiction, in the cases that we kind of see in formal treatment, is a chronic illness. It tends to have a chronic relapsing course for the kinds of severe cases with low recovery capital. We'll talk more about that we see in specialty care settings, i.e. SUD treatment settings. This is Bill White. Some of you know William White. He's been an architect in my book, an architect, a leader, along with others, Chuck O'Brien from University of Pennsylvania, Tom McClellan, others who have really understood addiction as a chronic illness, but we've really treated it as an acute care condition. Now, we have learned a lot and we've come a long way in terms of creating manualized psychosocial treatments over the short term, usually tested in 4 to 12 weeks implementation sequences. But I think it was people like Bill and others who recognized the need for not just 12 weeks of treatment, but really for, yes, that's important, detoxification, stabilization, acute care treatment, critically important, can save people's lives, of course, but that's where we've ended the story, and we without a recognition of the need to provide ongoing treatment and recovery support services. We've also learned, of course, that there are multiple pathways to recovery. I think our cultural default, our kind of general psyche operates along the lines of kind of when you have an addiction problem, what do? You go to rehab and you go to AA. That's pretty much kind of where most people are at when they think about an addiction problem in our culture. But there are multiple pathways to recovery. Most people, of course, do not go to treatment, to residential treatment, who recover from an SUD problem. In fact, more than half of people, it turns out, who meet criteria for SUD, admittedly at the less severe end, recover by themselves. They'd never go to utilize an external service. I'll just mention this because I think this is a very useful, underutilized resource that's available for download for free. It is the first Surgeon General's report on alcohol, drugs, and health. Just 7 chapters, nicely illustrated, and is available for free. It's good for educational purposes, I think, both for clinicians and for patients. So why is this notion of kind of chronic disease management or recovery management, which people like Bill White have epitomized and really explicated? It's in part because of what we learned about the clinical course of substance use disorders. We've learned that generally they have a fairly long course from age of first regular use up until remission. And you can see it here depicted in this timeline. Even after people recognize a problem, which can take many years before they're willing to admit it, and partly that's due to stigma and discrimination, the fear of discrimination. It can take, in adult samples, adult clinical samples, 8 years to get 1 year of remission after people start seeking specialty care. And importantly, after people achieve that first year of sustained remission, which in and of itself is a big achievement, of course, and involves big reprioritization of one's life, it takes 4 to 5 years of continuous remission before the risk of meeting criteria in the following year drops below 15%. Why 15%? Because that's the annual risk for meeting criteria in the general population in this country. So to be no more likely than anybody else in the general population of meeting criteria for a substance use disorder in the next year, if you've already had it, it takes 4 to 5 years of continuous remission. The good news is people with SUD, about 60 to 75% will achieve full sustained remission. So most will achieve this full sustained remission. It's actually a good prognosis psychiatric disorder, but it can take many years to achieve it. This is a study we did looking at people in recovery, and you can see here the inflection point in these indices of quality of life and well-being and functioning, which occur as people get into and sustain recovery. You can see that steeper incline in that first 5 years. In fact, right around that 5-year mark is where you see an inflection point, a change in the curve, which is interesting. As I mentioned, that 4 to 5 years before people are more stably in remission. This is reflected also in these indices of functioning and well-being. It takes about 5 years for people to climb up that, think of it as climbing up that mountain of functioning, well-being, recovery capital, and then decreases in psychological distress, which come down. You see there's a nice monotonic decrease, nice monotonic increases, but then you see these steeper decreases in that first 5-year period. What's slightly disheartening is despite these monotonic increases in things we would hope and expect among people who get into recovery, it takes about 15 years for people with a substance use disorder to achieve the same quality of life as someone in the general population. Now, to me, that is too long and places people at unnecessary risk for reinstatement of the disorder. I liken this to kind of a burning building, kind of where we've come in the last 50 years. I think we've done a good job in the last 50 years of recognizing the urgency, the importance, the significance of putting out the fire. And we've created important methods and treatments to stably, safely detoxify someone, to stably make them stable metabolically, and also to provide acute care services that can meet their acute needs in terms of stopping the fire. We've done a less good job in terms of then once the fire is out, to actually prevent it from restarting again. And what I mean there is fireproofing the building and providing the building materials. And I think most importantly, providing a building permit. You think about people who have a criminal record related to their alcohol or other drug use, can prevent them from getting a building permit to get a loan, to get housing, to get the basic needs met that they need to actually get a foot in the door and get some traction in recovery. And that's what I'm going to talk about today. How do we provide the building materials and the building permit that people need to actually fireproof that building, to help prevent relapse and recurrence, and to build a more stable and resilient recovery? So what is recovery? So I think recovery is both a process and an outcome. It's something that culturally we've talked about for maybe 100 years, maybe more, if you look historically, about the construct, the concept of recovery in addiction. So it's a cultural phenomenon that's recently been focused on scientifically from a clinical and public health perspective. And you can think of, I think we can think of recovery as, I think people often do, as going beyond remission to resilience, to building resilience against recurrence. I think people would say that remission is what is subtracted, what's taken away, i.e. the symptoms and signs of the illness, and return to a pre-morbid state. And I think the resilience part for me is kind of what's added. What's the fireproofing that occurs to produce recovery? And I think that recovery occurs at the intersection between remission and resilience. I just like this deck metaphor. Again, I like a lot of metaphors, but if you think about a deck, you can make a deck, it's replace a deck, and it's functionally fine. It works, it looks pretty good. But when you stain the deck, you weatherproof it. You are protecting it against the vulnerability to future hazards. So it's going to last longer. It's going to be more resilient. And I think that's one way to think about recovery beyond remission. So remission plus resilience, it helps to weatherproof or fireproof that the individual against the vulnerability to future hazards. I recently just came up with this kind of idea of a process of substance use disorder and how it changes over time in relation to the things I just mentioned. So I think there is a period of recurrence where people are getting some sobriety or early remission before relapsing. And then there's more stable remission, a period of resilience, which leads to recovery. And for some people, a kind of renaissance or rebirth, a feeling of a totally new sense of well-being and a new start, a fresh start or rebirth in life. And I think those are arguably some of the processes and stages that people go through in this process of substance use disorder change. So why is it then that it takes so long for people to achieve that early sustained remission and then to keep it, to get stably in remission? You've probably seen diagrams like this. This is from NIDA. It's adapted from NIDA's own website. But we all know that the vulnerability to addiction is multifactorial. It's genetic, it's biological, it's the interaction with the environment developmentally, and then exposure to a substance. The earlier the exposure, the greater the risk. And when the brain is exposed, there are changes in the brain, both functionally and structurally, which we call addiction. I just changed this slide to recovery. This is from addiction to recovery. So it's the same model, but this here I'm talking about recovery. Again, multifactorial. It's biological, it's environmental, it interacts with the environment. We can speed up recovery processes, arguably, by changing, making treatment more accessible, more attractive and engaging, by decreasing stigma and discrimination, by increasing social support and role models in the community, and by providing recovery capital, which I'm going to talk about. This middle part here, the yellow section in the middle, And I'll talk about how, not just psychosocially, how recovery capital, providing jobs, providing housing, providing social support, can increase optimism and hope for a better future, but also how it can change the brain and lead to better outcomes. We've learned, as I mentioned, from all the neuroscience that has been done in the last 30 years with better neuroimaging technology, that we understand the reward circuitry in the brain, how the brain is radically affected. These neurocircuits of reward, memory, motivation, impulse control, and judgment are radically affected depending on exposure, how long one has been using, how intensively, not just functionally, but structurally. You don't have to look very long or very hard to see in the bottom right here that ventricular enlargement and that cortical shrinkage, which occurs as a function of chronic exposure, in this case to alcohol. Now, when we think about people who are entering recovery, when you think about the functional changes in the brain, the structural changes in the brain, how do they manifest? And this is why it is so difficult for people to get and stay in recovery. There are two major processes that go on early in recovery. One is a heightened sensitivity to stress. The other is a lowered capacity to experience normal levels of reward. Why? Because people have been exposed to abnormally high levels of reward, and they've adapted, the brain's adapted to the presence of these abnormally high levels of reward, which is produced by these very potent substances. So when we think about recovery capital, that is to say, employment, housing, social support, recreation, the kinds of things that people need inside themselves and outside themselves to mitigate that relapse risk. How does that affect the brain, right? If you think about addiction as a disorder that will radically altered and damaged brain neurocircuits, could social factors, housing, actually change the brain? Well, it's interesting when you look at these factors, and there's been a lot of work done, particularly with things looking at social isolation, for example, and disease and premature mortality. This is a striking meta-analysis, 150 studies looking at the effects of social isolation on premature mortality. And what they found was in this study, 150 studies, showing that isolation, social isolation in human beings produces the same level of premature mortality as smoking cigarettes, independent of those other factors. So just those social isolation, there's something about social isolation, just generally, which is impactful for human beings. This is why, we all know that when we are stressed out, we talk to people, we talk to other people, we talk to our friends, our neighbors, our family, and we get support. We feel better, right? And the reason why we feel better, of course, there is a neurobiological, neuroendocrine system that's going on inside of our soul that is affected by our social support. So social support, yes, of course, we feel better, but under the hood, neuroendocrinologically and neurobiologically, there are changes. And we're understanding now how some of that social support affects our neuroendocrine and neurobiological system. When we think about the lowered capacity, so that was stress. Now think about lowered capacity to experience reward. Sometimes people refer to this as kind of hedonic deafness, or the inability to experience normal levels of reward in this early post-acute withdrawal period, which can go on for many months, even many years. When you look in people, in the human brain, the relationship between social support and social status and the capacity to experience reward, we see this nice linear correlation, nice linear relationship. The more social support we have, the more capacity we have, the more receptors density we have to be able to experience normal levels of reward. The same is true of social status. The more access to resources a human being has, the higher the density of these social, capacity to experience rewards. In this case, the dopamine D2 receptor system. Now, of course, we don't know which way this is going. These are correlational data. So is it that people with higher dopamine D2 receptor density have, just more likely to be able to get more social status and social support, or does more social support and access to resources increase the capacity to experience reward. Well, this is a study that actually looked at that, and they manipulated the environment from social isolation to social integration. This was among primates, but this was monkeys. And they were all exposed to cocaine. They were using a lot of cocaine. And they were all individually housed initially, these monkeys, had access to cocaine, which they used readily. And there was no difference when these monkeys were individually housed in their level of dopamine D2 receptors. Now, when they were put into troops, which they love to be together, to hang out together, monkeys like humans, what they found was that in the monkeys that were able to have access to resources, the dominant monkeys, they showed a substantial increase in dopamine D2 receptor density compared to those monkeys who were subordinate monkeys who did not have access to those resources. Higher density increases in dopamine D2 receptor density resulted in a lower incidence of return to cocaine use. So interestingly, again, the environment interacting with biology here in the sense of more social support, more mobility through the troop, greater access to resources produced this increase in dopamine D2 receptor density, which reduced the use of cocaine. So if you think about that from the human perspective, if we actually facilitated greater access to and availability of recovery capital, that is to say, access to resources that can help people in their recovery, it may induce neuroreceptor and neurochemical change that reduces the risk of SUD recurrence. It's reflected, of course, psychologically as instilling hope, empowerment, increasing environmental control and social contact and social mobility. This is where we experience this psychologically. But under the hood, there again is a process going on through the provision of resources or recovery capital. Historically, of course, we've tended to focus on two major ways to address addiction. One is through professionally directed treatment, and the other is through mutual help organizations, which have been around for a long time. Now, there is a third new kid on the block. These are new recovery resources which operate outside of the forum of formal standard treatment and mutual help. It's interesting, how we've changed. This is from the National Institute of Drug Abuse. I think many of us associate NIDA with perhaps being or having a more reductionistic focus purely on the brain neurocircuitry. But this is NIDA's view of what comprehensive drug addiction treatment looks like. I think in the middle, this is what we would normally associate with comprehensive drug addiction treatment: good assessment, screening, assessment, make sure we catch everything, good case management, and continuing care. But look around the edge. What's interesting to me here is all the other things that NIDA views as providing comprehensive addiction care. That is to say, mental health services, medical services, educational services, vocational services, legal services, family services. Interesting that it's encompassing now not just treating the pathology, but directly, but addressing the social deficits, the social determinants of health, which can instill hope for recovery, that people can get some traction, as I mentioned, start the rebuilding process of their life, which can reduce biobehavioral stress, of course, and help people feel better. What do they look like, these recovery support services that have emerged? Now, mutual help organizations have been around the longest. I'll talk about those briefly. But there's a whole cadre of other recovery support services which have emerged, including other peer-based recovery support services. I'm sure you've heard of recovery coaching and recovery coaching models. These are born out of the mutual aid movement, the idea that a peer with lived experience has the capacity to engage other people who are suffering from addiction and provide hope and facilitate linkages. Recovery residences have been around a long time, but they are growing in diversity and capacity. Recovery community centers are literally the new kids on the block. I'll talk about those. And recovery supports in educational settings. So all these recovery support services, the RSS here, is designed to enhance the chances of remission and resilience that can produce recovery. The way that it does that, of course, is by providing access and linkage to recovery capital, which can then produce these biopsychosocial changes. So what about these recovery support services? I'll just give you a flavor of what we're learning, what they are, and what we're learning empirically about how they can help in this new paradigm of shifting away from addressing purely the psychopathology of addiction to addressing the psychopathology and the other needs, as I mentioned, that are around the outside of that circle that NIDA now espouses as providing comprehensive treatment. So mutual help organizations, there are a lot of these that have grown over the last 100 years. Most notably Alcoholics Anonymous, the 12-step model, but many others have emerged either inspired by or in opposition to 12-step approaches like Smart Recovery, LifeRing, Women for Sobriety, Moderation Management. Many other groups have emerged and are growing, and we're starting to do research now on these other groups. The most research by far has been done on by far the largest group, which is Alcoholics Anonymous. We just summarized the science in this area last year, published the Cochrane Review in this area. Strikingly, what we found was that providing a simple linkage, a clinical linkage to Alcoholics Anonymous for those with alcohol use disorder, mostly severe alcohol use disorder, produced outcomes. Again, a simple clinical linkage to these peer support services provided outcomes which were no different than more comprehensive addiction treatment, like providing 12 sessions of cognitive behavioral therapy, and produced much higher rates of remission, 20 to 60% higher rates of remission by linking patients to groups like AA for alcohol use disorder. Not only did it produce higher rates of remission, quite substantially, but it also dramatically reduced healthcare costs by providing linkage to these free, indigenous, ubiquitous recovery support resources. We estimated that in 2018 dollars would save about $10 to $15 billion a year, $10 to $15 billion a year in healthcare costs, and improve outcomes by providing linkage, in this case to Alcoholics Anonymous, for those with severe alcohol use disorder. Now, why is that? Why does 12-step facilitation work better for producing higher rates of sustained remission over time? Well, here's the answer, is because it's mobilizing. This is what we have found in many other, dozens of other studies that have looked at the mechanisms of behavior change through which groups like AA confer benefit, is that they mobilize the same kinds of therapeutic mechanisms that are mobilized by formal treatments, that is to say, by boosting self-efficacy, coping skills, motivation, changing social networks, but it does so over the long term in the communities in which people live for free. So it provides easy access, it's cost-effective, and that people can utilize it. It's an indigenous chronic recovery support service. And this is why I describe groups like AA as the closest thing in public health that we have to a free lunch. And this is why I think we need more of these kinds of things, that they can sustain, they can provide local access to sustain, to resources that can sustain recovery in the environment in which people live. Here's another one, sober living. Sober living environments have been around for quite a while. They are increasing in their diversity and capacity all around the country. They're becoming more cohesive and more refined and more organized, in part because of the potent effect that they have been shown to have, both in terms of crime recidivism, SUD relapse, and improving employment rates, as well as reducing criminal activity. Look at the effect sizes here in terms of arrests and abstinence. This is a randomized controlled trial. Massive changes, almost doubling the effects in terms of employment, reducing incarceration, reducing relapse risk, and also, very importantly, producing economic benefits. So again, not only helping with the kind of things that most people care about, public health, public safety, are people working, are people utilizing expensive healthcare services, but you put all that together and we're saving about $30,000 per person when they're randomized to receive residential sober living, if you will, or residential care versus going home as usual. What about long-term clinical models? We've been a bit late to the party in terms of understanding how to treat addiction as a chronic illness. Michael Dennis, Christy Scott at Chestnut Health Systems in Illinois have done some very compelling work. So this is what they did. They call these recovery management checkups. And this is, you can think of this as really treating addiction akin to the way we would treat diabetes or hypertension, other chronic illnesses, medical illnesses. So what they did was they randomized patients with severe substance use disorder to receive either, they all got treatment as usual after their initial phase of treatment, but half of them were assigned to an assessment plus a conversation whereby if they were doing poorly, that was shown on the assessment, they were redirected back into treatment using a motivational interview, compared with just assessment only. And what did they find? The people who got the assessment, again, this was every quarter for 4 years, okay? So kind of chronic disease management. What did they find? The people who got the conversation, this is within a 1 hour period, an assessment and feedback about how they were doing, and if they were doing poorly, a conversation about getting back into treatment. They got back into treatment 3 years earlier compared to those who just got the assessment without the conversation and the linkage. 3 years earlier. Not only that, the people who got back into treatment had lower levels of substance use, and it was shown to be cost effective. So again, a kind of a no-brainer, right? If we actually were to treat addiction as a chronic illness, check in with people every quarter, just for an hour, have a conversation. If you're doing poorly, link them back into treatment. And what do you find? You get them back 3 years earlier. 3 years, I mean, that's a huge amount of time for somebody to be, again, they're getting treatment as usual, but taking that much longer to get back into treatment. And those who got back into treatment had better outcomes, and it was actually cost effective. Again, good news. One last one I'll mention is recovery community centers. We're doing a big study right now trying to expand the research infrastructure on recovery community centers. We've also done a regional study in New England looking at these recovery hubs. And recovery community centers you can think of as community-based hubs that provide one-stop shopping for recovery. They provide access to or linkage to the kinds of recovery support kind of ingredients that people often need: housing, job training, jobs, education, legal services, mental health services, other kinds of services. And these are designed to be located in the hearts of communities that provide a beacon of hope for people who have substance use disorder, who are seeking recovery. These are some of the things we have found in a study of 35 centers across New England and New York State, the kinds of things that these centers provide. So they provide access, as you can see, to a lot of recovery capital, a variety of things from mental health, child services, family support, housing assistance, getting a CV together, getting linked to job people who can provide job training and job access, recovery coaching, smoking cessation, recreational activities. Who's using them? People with principally alcohol and opioid use disorders tend to use them the most. And over on the left-hand side here, you can see these are not just utilized by people in their early stages, although certainly they are used by people in that first year. As you can see here, the orange segment and the gray segment, about 50% roughly are using, public people actively using in the first year. But look, you also got people in that 1 to 5 year period, about between a quarter and a third are people in that early phase. That again, that unstable phase, that phase I showed you where people are climbing up that early steeper mountain, where they're trying to get more functionally better, improve their quality of life, get more recovery capital. And that's where these things are coming into play. What's notable when you look at people with these substance use disorders, they're not all the same in terms of the quality of life and recovery capital. What we have found is that people with stimulant and opioid use disorders tend to start off at a disadvantage relative to people with other substance use disorders. And in this study, what we found was that people with opioid and stimulant use disorders started off their recovery journey 1 standard deviation lower. That's a huge, massive disadvantage for people with opioid and stimulant use disorders. It took them 2 to 3 years to get to the same level as people with other substance use disorders, 2 to 3 years. That's why these centers, I think, are particularly valuable for people with opioid and stimulant use disorders. We have found, consistent with the theory of these centers, that they boost recovery capital and thereby boost these functional indices and thereby increase the chances of ongoing remission. We have found support for this model in preliminary, with using these preliminary data. So this is why, in part, NIDA is now funding a large grant that we are running to expand the research infrastructure so more people can do research on these very important recovery support services. This was a review, systematic review we did for SAMHSA a couple of years ago now, but this is across these major recovery support services, and you can see the degree of evidence for most of these services is low, with the exception of the clinical models of recovery management, continuing care, mutual health. But the new kids on the block are really awaiting more research and research focus to boost the quantity of research, to boost the quality of research. But I think there is, based on the preliminary findings, that providing access, this other access, not just addressing the psychopathology, addressing the social determinants, the recovery capital aspect, we can actually boost and sustain and maybe increase the chances of sooner remission and more stable remission sooner. So in summary, we've learned a lot in the last 50 years, right? If you zoom out, you think about all the things we didn't know 50 years ago that we do know now about the genetic etiological factors, the epidemiology, the phenomenology, the typologies of substance use disorder. We've addressed substance use disorder. We've put the fire out. We've become very good at putting the fire out, but not so good. We haven't focused as much in how do we prevent it from restarting? What do we need to do to fireproof the building, to provide building materials, to provide the building permits so people can actually get a foothold in recovery and get that foothold more stably secured and sooner. We're learning a lot about recovery and the recovery process. I think there are theories of early relapse that we might be able to use to inform our models of more stable remission and recovery over time. And there are an array of growing recovery support services. I mentioned some of them today. There are recovery coaching, there's recovery supports in collegiate recovery programs, there's recovery high schools, recovery community centers, recovery housing, and mutual aid groups, which are growing. We're doing a big study right now looking at smart recovery, a cognitive behavioral mutual aid group, the first naturalistic study to examine the real world effectiveness of other kinds of mutual help groups, which are needed desperately because people need options, other kinds of groups that are better fit for them. And I think, what we'll find over the next 50 years, in addition to all the, I think, genetic and biomarker identification, which I think is promising, we're going to learn a lot about how the social context, the social environmental context, how we can support people, providing access to recovery capital sooner, make that more attractive, engaging, and accessible, and lower costs that we can improve rates of remission. So I want to thank you all for coming, for listening to me today, and let me know if you have anything you want these slides or any of the papers that I presented. Happy to send those to you. We will have much of this on our website at recoveryanswers.org in our repository there. But please reach out if I can answer any questions, and maybe we have time for a few questions, Tingyi.
Indeed, we do. And then also, just before we start doing questions, I want to launch our second poll. So we want to get some information about your professional background, and this won't be shared, but I'll keep this up for a minute. Yeah, and we welcome any questions. You can go ahead and unmute and just speak to the group. And if we have time, I'll bring in some questions from the chat box. All right, so I'm seeing one question from the chat from Isabel O'Malley. So the question is, how can people in rural areas get better access to RCCs? Any examples of rural communities with RCCs that have had high attendance or innovative outreach?
Yeah, I think there are some examples around the country, in Montana, in Vermont, which have examples of more rurally based recovery support centers. I think that, one of the silver linings of COVID has been, the push to virtual telemedicine and teletherapies, and us being in boxes and being able to communicate very effectively and efficiently this way. And I think a lot of recovery support centers, recovery community centers, have made use of this technology. So that's one way I think that we've learned as a result of COVID that we can do more outreach and create greater linkage virtually via platforms like Zoom, which I think is going to be a keeper. And I think that's something that we want to be able to build as part of the infrastructure now of recovery supports, so that more people can get access to these conversations and get access to information that and facilitate linkages to resources that they can get in the communities in which they live, or via platforms like Zoom. So I think that's one way that the payment system needs to incorporate that kinds of technological infrastructure going forwards. And I think we've all learned that the value of that to bring people closer together and provide them access to these resources. Thanks for that great question.
Thanks.
Might I ask a question? Dr. Kelly, this was a wonderful, comprehensive presentation.
Hey, Andrew.
Yeah, how are you? Great.
Good.
In some of your work, a lot of the work that you described sort of suggests that abstinence has been one of the measures that was looked at as outcomes for some of these studies. And I'm wondering if you've been looking at or comparing, various pathways to recovery that are non-abstinent pathways, which is something that actually has hit the news recently. With Demi Lovato's California recovery, I think she's calling it. But so I'm curious about how you're thinking about and looking at the difference between abstinence pathways and non-abstinence pathways.
Yeah, I think probably 30 years ago, we started to look at more continuous measures of recovery indices and changes in substance use. We're still, I think we're just changing now. The field is just changing now to look at other indices, including things like quality of life and functioning. As you know, Andrew, we're starting to incorporate more of those measures. A little late, but better late than never, to look at how changes in substance use relate to actual functioning and well-being. And we do know, of course, that harm reduction approaches and any reduction in exposure to toxic substances is going to produce health benefits and functional benefits. And so any moves in that direction is good news. And of course, things like motivational interviewing and other kinds of therapies now, which are designed to meet people where they're at and help engage them, rather than say, go away and come back when you're ready, at which point, people are at risk of dying. To engage people, meet people where they're at, and help move them along before it's too late, before they could actually overdose and die. So I think there is a movement and greater recognition and understanding of the importance and significance of harm reduction and looking at reductions in use, as well as abstinence and remission, and all of these indices. But these other indices, as you mentioned, have been left out historically, but I think they'll be incorporated and are being incorporated now. So thanks for that.
Thank you.
Great, thank you so much. I think we have a question from George Brock, I believe.
Thank you very much. Hi, Dr. Kelly. Appreciate this.
George.
Just wondering, given the emerging recognition of the relevance of social model of recovery, that's Borkman and Kaskudis, they originated the first notions, and the research that's emerging on social model programs like peer support and recovery community centers and recovery residences, really be interested in what suggestions you have for promoting the funding shifts that are necessary to support these programs and their improved outcomes. And here's the key: without threatening the livelihood of clinicians and other allies.
Well, that's a great question. I think there's, our clinical outcomes are not great. We've got tons of room for improvement. And I think part of it has been the lack of focus on these other factors, the housing, the stable housing for people who need that and could benefit from that, the job training, job support. We have this wonderful program in Massachusetts we're just doing an evaluation of called Access to Recovery, which provides job training, provides housing for 6 months. Those kinds of things, somewhere to live and a job, are so key to instilling hope. Now, I think we're coming around gradually to understanding, including NIDA. You saw that diagram that NIDA now espouses as being comprehensive, good quality, comprehensive addiction treatment, is encompassing housing, training, education, mental health services, medical services, legal services, all the things that I don't think we would have associated 10 years ago with comprehensive addiction treatment. I think incorporating many of these things, and I think the new administration now, with the just coming into office, are really focusing on not just addressing acute care needs and addressing clinical pathology, which is of course critically important, but also expanding the repertoire of options and appropriation of funding to fund these kinds of things better and do more research on them, so we can look at their utility from a public health standpoint. So I think the world is changing. It's going to change, I would say, over the next 20 years as we start to focus on this and look to see the extent to which providing these services can improve outcomes clinically.
Thank you.
Yeah, thanks for the question.
And I just want to be mindful of time. We are coming up on 1 p.m. Dr. Kelly, do you want to stay on for more questions or?
Yeah, I think we have to officially end at 1, but I'll stick around if you have questions. And I want to thank you all so much for coming. Thanks for the great questions. Thanks for putting the questions in the chat. And join us next time. We'll have another one, I think, in about a month, right, Tingyi? I forget. Yeah. So stay tuned, and we'll be reaching out to you with other information about the future webinars. But thanks so much for coming today. Appreciate it. You want to stop the recording, Tingyi?
Sounds good.